Thank you. Yes, my presentation is full arch concepts, and this PowerPoint is basically me. I'm a general dentist, and I started lecturing about 6 years ago on full arch implant rehabilitation. In 2017, I wound up opening up my own dental lab, so everything you'll see here in the presentation is from our laboratory. In that laboratory, we were able to develop the full arch screw, vortex screw, which is now just patented about a week ago, and we'll talk at the end of the presentation about the Smile Mission Foundation. Social media is a big thing, so I'm Implant Diplomat and I'm LA Dental Implant Lab. But today's presentation is going to be on the diagnosis, digital planning, full arch reconstruction concepts, and also taking into consideration soft tissue concerns. So I did my residency in Brookdale Hospital in Brooklyn, New York, where the population was 8.5 million people, and a single person made $100,000 in New York. So planning an implant is very easy, and people can afford it. But I moved back to Louisiana, in my hometown, where the population is 150,000 people, and for a single person, they can only make $30,000 a year on average. So it's very difficult to give people treatment and have them afford it. So what we try to do is strive to bring down the cost and provide the level of dentistry of what they need, right? This lady was missing a tooth, and we're recreating the biology around the natural tooth concepts. This is the day of delivery of her tooth, an FP1 tooth, or give back a tooth that was missing, recreating FP1 tooth for someone that never had a tooth. And it's true, you really do change people's lives whenever you do this, but nobody talks about key concepts for full arch and recreating FP1's concepts. All of this, keep in mind, all of this that we do is facially integrated, prosthetically driven, digitally performed, but biologically integrated. Right? So this is why I lecture. This lady has been in treatment for 3 years. This is how she started, and this is where she is right now after treatment for 3 years. You see, she had her teeth taken out, and she had 4 maxillary implants and 2 mandibular implants placed by very talented dentist. And then he referred her to someone else to get teeth made, right? And this is the teeth that she has in her mouth. Man, please put your teeth in your mouth. This is what she starts to look like. And this is her smile. Mind you, she spent $20,000 on treatment, and this is the final product of her smile. The reason why I'm showing you this is because she went to go see another dentist because she was unhappy with her smile. And the other dentist said, oh, you need more implants. We're going to put more implants. So we put 2 more maxillary implants and 3 more mandibular implants in her mouth. Not yet working the patient up for prosthetics. He said, let me just go ahead and remake your denture over again. So this is her new denture that she had made for herself, right? This is the second time she's had a denture made, right? And if you look at her x-ray, she's got subcrestal implants placed, crestal implants placed, and supracrestal implants placed, but yet we haven't looked at the aesthetics of her case or driven this biology speaking. So they made another denture, and this is the final denture that they made for her. And at this point, after 3 years of service, she was ready to, she said, this is going to be my smile, and this is how I'm going to end. It's hard to understand how someone can look like this for the final treatment plan. And what I'm telling you guys is this room is filled with talented surgeons. And we need to drive the education for the future dentist so we don't have issues like this with our patients, and we don't have issues like this in our clinicians. And things can happen, right? Things happen, but we have yet, or any clinician has yet to look at the biotype of this person and look at where the implants are placed, and they haven't even considered the soft tissue considerations for a case. So she went from looking like this, terrible, to this, to that's her final treatment plan after 3 years. I'll get back to this, but I want to really talk about this key concept, and it's the wettability of the implant surface. Reducing the hydrocarbons, and there's literature after literature after literature to talk about how prevalent is this in the implant world. This is what a hydrocarbon is. Hydrocarbons are hydrophobic, right? So if you remove the hydrocarbons off of the implant surface using the plasma X motion, you increase the wettability of the surface of the implants. So we know that 26 to 55% of implants contain hydrocarbons the day that you open them up from the package, even if they're really well cleaned. And if you look at literature, just plasma X treated reduces the hydrocarbon load off the implant, right? Which increases the wettability of the implant surface. Wettability of the implant surfaces is critical in on our long-term success of our implants, and we have studies that show that plasma-treated implants, increasing bone concepts, you get more bone faster around an implant. Why is that clinically significant? You have a patient like this who comes into you for treatment. Her husband just passed away. She has not been a dentist in any years. She's been the caregiver for her husband. She has extreme amount of bone loss. She has no bone available for implants in her maxilla. And she's asking you to take her teeth out and place a full mouth of implants because she saw a commercial from a TV. And so she thinks you could. Now, in your clinical practice, if you say, look, this is too difficult, I'm taking your teeth out and I'm putting you a denture, you're going to heal. There's so much bacteria and infection. I'm fine with that. And then come back and place the implants. In cases like this, it's very difficult to work these cases up without proper planning. And look at the photos. Look at the massive amounts of bone loss, the infection. She hasn't brushed her teeth in 40 years, right? Look at the bone and soft tissue consideration. She's got no keratinized tissue. All of her tissue is loose and friable, right? And so if we're taking teeth out and we're going to have to place implants, what about the soft tissue considerations for this patient? But also, she's bimaxillary protrusive. So when placing implants in the bone, we're going to have to bring her back aesthetically and prosthetically to be able to recreate her bite in the proper position where it never was, but where it needed to be. So this is basically what I showed her. Ma'am, this is how many teeth you should have. This is how many teeth you do have. Pretty much everything's a loss. We're going to have to take your teeth out, put 6 implants at the top, 6 implants on the bottom. But how am I going to go about do this? There's a step-by-step method for this. Step 1 is data gathering. I'm going to take upper and lower intraoral scans, but I'm also going to start taking some facial photos and do facial analysis to try to figure out where I'm going to bring her case or where we're going to finally drive her case. Studying for her face, we're going to do a smile simulation and figure out where she can look, what she can look like. Now, this is really good for her, but this really doesn't help me out because I need to take the 2D world and bring it into the 3D world. So the 3D world, we create an ideal aesthetic wax-up based on where the teeth should be in the patient's face, right? Facial scans, facial photos, intraoral stitching. Plan our implants in step 4 in the correct ideal tooth positions based on available bone, whatever bone we have, what minimal bone we have. This is going to be our maxillary implant positions and our mandibular implant positions. And where do we go here? Prosthetic considerations, FP1, FP2, FP3. For her, since there's so much bone loss and there's 20 millimeters of prosthetic space, she's going to be an FP3. So, surgical guide design. I've done advanced bone segmentation in my maxilla and my mandible. I'm going to create a tooth positioning index guide for my maxillary and the mandibular arch. Remove that guide. I'll have a bone reduction guide to level out the plane for the bone, and then take a superstructure drill guide on top for both the maxillary and the mandible to be able to place my implants in. Because once you take those teeth out, you lose all references, and it's a bloody mess, and you can't see anything that you're doing from the surgery. So having a surgical guide for these cases is critical. Step 5. After designing surgical guides, we're going to design our immediate 3D printed prosthetics. They're going to be chairside delivered. Keep in mind, when you design the provisionals for this case, you need to make sure that you're off the bone by 2.5 millimeters to allow for soft tissue keratinized gingiva involvement. So this is the day of the surgery. Bone reduction guide in place. This is going to be how our guide. Take it out, and we're going to reduce our bone, place our implants through our guide, and plasma X motion every single implant. We need to get great bone-to-implant contact immediately if we're going to immediately load implants in this patient's mouth. We're going to do a pickup conversion for her, top and bottom, immediate load provisionals. She walks out the door with upper and lower fixed provisionals in her mouth. After healing for 3 months, we need to evaluate the soft tissue. Now, keep in mind, I did no soft tissue grafting. All I did was recreate biology using PRF and biological factors to be able to get thick band of keratinized tissue around our full upper arch and lower arch. We'll take our facial photos from the provisional that we 3D printed in advance, and we're going to digitize her face and her smile and be able to bring her back, her envelope of function, back into a FP1 position. Now, it's hard to do this with normal screws in today's technology. So we use the vortex screw, which uses angulated screw channels direct to multi-abutment without a tie base. We milled upper and lower provisionals, actually milled 2 custom abutments from the anterior. We created an exocad library for Megagen, be able to mill directly to implant platform. This is our abutments in place and provisionals in place for the upper, lower, and our bite. Bite is key. We're in the correct CR VDO position for this lady. This is going to be, if she accepts this case, we're finished with our treatment plan. All we have to do is mill this in final zirconia, but we've completely changed and given her teeth that she's never had before. And this is her before and after smile. And we're done. She accepted the case. She loves it. So for her upper arch, we're actually going to mill this in zirconia, monolithic, with no cutback. This is going to be stained zirconia. On the lower arch, we're actually going to mill a titanium bar substructure because we had a molar cantilever off on both sides. And then we deliver our final upper and lower. It's been 1 year in function now. This is her final result. This is her final result. You guys remember that lady that I showed you guys at the beginning of the lecture? What do we do for someone like this? Keeping in the same concepts, how do we drive this? Now, if we could open up her bite and get her in a better position, but we can't because her VDO is correct. She actually is in a decent CR position. So we're going to digitize her upper and lower denture, but take an intraoral scans, and we're going to mesh those scans in exocad using her face and alignment. This is the pre-op, and this is her digital wax up. This is the pre-op. This is her dentures stitched to her mouth in exocad, and that's her final prosthetics that we're going to deliver for her. Mounted bites in exocad. I'm going to do FP1 over FP3. This is the next day. This is actually last year, October the 20th of 2023. We delivered an upper and lower provisionals. Now, you see that concept and you think, do we take out all the implants? Do we start all over? Is this a surgical intervention? Just using the concepts of biology to recreate her smile and give her an FP1. This is where she started. This is where we finished. This changed her life and changed her perspective on implant dentistry. And all we did was harmonize her soft tissue and give her back biology. I said, ma'am, smile as big as you can, smile bigger, smile, 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 smile. And all I did was use ovate ponics on our provisionals to scalp the soft tissue to be able to give it a FP1 on top and FP3 on the lower arch. These are the final photos and a comparison of where we started and where we're going to end and where we ended for a case. I'm going to end my presentation, but I'd like to share with you one thing since I have some time. Once a year, I take dental students to Mexico. And we do so much in our private practices, it's important that we give back to the community. This is an orphanage. These kids don't have a home. They don't have families. They were abandoned. And this was a room in the orphanage. It actually had a dental chair in it. And these 8 girls did not have a bedroom. They didn't have a bed. So while we were there in Mexico, we saw them as patients and we did dentistry on them, fixing their teeth because they haven't seen a dentist in their entire life. And by the end of the project, we were able to create the girls a bathroom. 8 12-year-old girls. And we also changed that room and built a bedroom for them. This is giving back. We've gotten so much. Give back to other people. Do better for others. That's what's really important in life. Thank you.